Dr. Elwing, Dr. Shaw, thanks for having us here at the University of Cincinnati Medical Center. We're enjoying the conversation. Let's talk about PoPH patients and how they are screened.
So all patients who are liver transplant candidates are seen in our multidisciplinary clinic, and everyone is screened with essentially with an echocardiogram and a stress test. And what I have found really interesting is that you would think that patients that are walking around with pulmonary hypertension have symptoms, but a lot of times many don't. So everyone needs an echo, and you really need to pay attention to the echo to make sure that when it's read with some characteristics of what the pulmonary pressures are like. How is the heart functioning, and are they elevated or are they not? Because a lot of times they're not recorded, and you might have undiagnosed pulmonary hypertension because either the echo was low quality or not. So for us, that has become a critical component. We have to have some prediction of what the PA pressures are like when they have the echo. If they're elevated, then I usually have Dr. Elwing see them right away as long as I've ruled out fluid overload. Commonly in patients that have kidney failure, fluid overload is a common reason why pulmonary artery pressures are elevated. But if we rule those things out, then she sees the patient and usually gets a right heart cath, which is the gold standard. And that must be performed by someone who is looking for the specific characteristics on the right heart cath to diagnose pulmonary hypertension. That can't be done just as a simple right heart cath, and I think she'll get into that. But for patients that are on the list that have a normal echo, then essentially just follow-up echocardiogram should be performed. We do them here at University of Cincinnati once a year, but otherwise you want to make sure that you're just checking up on those things while they're on the waiting list. And then if the presence of portal pulmonary hypertension is confirmed, then she sees them and she manages them to get them ready for the operating room if it's possible.
So when I get a referral with a high PA pressure or some right ventricular dysfunction, we'll go through the algorithm of working out pulmonary hypertension. Maybe they have another condition. Maybe they have lupus. Maybe they have blood clots, and I want to know why. And I'll come to the conclusion it is portal pulmonary hypertension after I rule out other things I could modify, because we have to look at the whole picture to have the best outcome. When I get the right heart cath, then I look at the resistance in the circuit, I look at the cardiac output, and I also look at the mean pulmonary pressure. If the mean pulmonary pressure is less than 35 from the get-go, I have someone with mild disease, I might be able to start them on drugs and say, well, we're still doing fine, the patient is very functional, their right ventricle looks good, they can still proceed with listing and stay on the list while I continue to treat them and follow them very closely. We'll be repeating that right heart cath maybe every 6 months as we're watching them, because we don't want to lose the window. We don't want to undertreat, because this can go pretty quickly, so we always have to be thinking ahead. If their pressure is higher, as we know and we've talked about, if your mean pressure is more than 35, you would possibly not be someone that could proceed with transplant if you have a high PVR. Okay, those individuals, they would have to then not be on the active list, and then they keep following with me until they reach those hemodynamic goals. And for me, I also like to see that the right ventricle looks very, very normal, and that helps me know they will tolerate the surgery and all of the hemodynamic changes that go along with it better than if they had any RV dysfunction. And if you look at the algorithm, which we're showing here, we see a patient being evaluated for liver transplant. We look at them in an expert center, both for liver transplant, familiar with managing portal pulmonary hypertension, as well as someone who manages portal pulmonary hypertension itself. And then we separate out the groups. Those with pulmonary hypertension that's significant, that is not possibly a candidate at that time, not possible liver transplant candidate at that time because their mean is high, or those that can go on and be transplanted because either their pressures are normal or they're only mildly elevated. And we continue to aggressively manage them to goal. And there are people, unfortunately, we don't get to goal. And we're very honest with them from the get-go, what we're doing, why we're making those changes, why we're pushing them so hard, with their understanding that if we don't get there, we will manage them medically as long as we can to keep them feeling well.
Well, you make it crystal clear, doctors, that these patients who come here with pulmonary hypertension and in need of liver transplantation are definitely in the best of hands. Thank you very much.
Thank you very much.